Welcome, everyone. My name's Terry Lakowski, and I'm the program director for Us2, and I'll be your host tonight. Tonight's webinar on shared decision making is episode 2 in a 5-part series called What is Right for Me in My Prostate Cancer Treatment. This webinar is sponsored by Pfizer Astellas. We are so excited that we can all be together this evening through our amazing world of technology. And we have people joining us from all over the US and Canada, Belgium, Tunisia, Finland, Italy, Cameroon, Australia, and the Bahamas. One of the challenges men face in selecting a treatment for prostate cancer is that there's no single standard that applies to every situation. With this webinar series, What is Right for Me in My Prostate Cancer Treatment, Us2 will try to help patients and caregivers understand their options and provide information to help each person make the best choice for his own unique circumstances. Us2 is here to empower men diagnosed with prostate cancer and their loved ones with the educational resources and support services to help fight prostate cancer. Our website offers a wealth of information at no cost to help make informed decisions on prostate cancer testing, active surveillance, treatment options, and management of side effects. Through our support groups, and now due to COVID, close to 100 virtual groups, newsletters, educational materials, and events, the Us2 will help transform resignation into determination and fear into hope. So I want to just go over a few housekeeping items before we start. We've received literally hundreds of questions during when you all pre-registered. So we have some of those questions ready to go, but we also have a Q&A box. So any questions that you have, be sure to put them in the Q&A box. And our presenter, actually we have a Q&A host tonight, Dr. Murphy, who I'll introduce a little bit later. He'll be watching that Q&A box for you. So you can also use the chat box, but the chat box is really for just kind of general comments. If you're having any issues, just put those in the chat box. If you want to say hello or something, we'd love to have you to give a little shout out in the chat box. So we have so much to cover tonight, so let's get started. I'm really honored to introduce our presenters. So first off, we have Lillie Shockney. Lillie is well known in the cancer field, especially in navigation, survivorship, patient-centered care, preservation of quality of life, end-of-life planning and care, improving the cancer patient's experience and clinical outcomes. Lillie has worked at Johns Hopkins since 1983. In 2008, the president of the Johns Hopkins University and their board of trustees appointed her to a distinguished service faculty chair. This is the first and only time in the history of the institution that a hospital nurse has been appointed to a distinguished service designation. She continued to climb the academic ladder and in 2016 was promoted to full professor. Lillie takes great pride in being the founder of the Academy of Oncology Nurse and Patient Navigators, which started 11 years ago and now has more than 8,900 members. Tonight, we also have Aisha Langford joining us. Aisha is an assistant professor in the Department of Population Health, Division of Comparative Effectiveness and Decision Science, and co-director CTSI Recruitment and Retention Corps at the NYU Grossman School of Medicine. Dr. Langford's research explores how health communication can improve individual decision-making and reduce population health disparities for conditions or behaviors that lead to preventable mortality and morbidity. She has done work in cancer prevention and minority clinical trial participation in community-based settings. Her current work has expanded to include cardiovascular disease broadly, with a particular interest in hypertension-related decision-making and patient-physician communication. Tonight, we are also really fortunate to have Us2 board members as our moderator and our Q&A host. Dr. Stacy Loeb is a professor of urology and population health at the New York University School of Medicine and the Manhattan Veterans Affairs Medical Center. Dr. Loeb is an expert in prostate cancer with more than 300 peer-reviewed published articles, and 10 book chapters. Dr. Loeb also hosts the Men's Health Show on SiriusXM, US and Canada Satellite Radio, and serves on the AUA Public Media Committee. We also have with us as our Q&A host, Dr. Adam Murphy, who is an assistant professor of urology and preventive medicine at Northwestern Medicine. He is also on staff at Cook County Health and Jesse Brown VA. Dr. Murphy has been studying the health disparities faced by minorities in prostate cancer, and especially African Americans. He has been looking at the role of vitamin D deficiency, genomics, and biomarkers and disparities for men at risk and who are already diagnosed with prostate cancer. Information and opinions expressed in this presentation are not recommendations by us2 for any medical treatment, product, service, or course of action. Please consult your doctor about your specific situation before embarking on any health program. So let's get started. Now I'm really honored to introduce my friend, Dr. Stacy Loeb, who will get us started. So welcome, Stacy.
Thank you so much, Terry, and thanks to everyone who's joining us today. This is going to be a great webinar, and I'm very excited. I think we'll start the discussion around shared decision-making about prostate cancer screening. So let's turn to you first, Dr. Langford. Can you talk a little bit about prostate cancer screening and the importance of shared decision-making? Perhaps even starting with what is shared decision-making?
Sure. So shared decision-making broadly is a collaborative process by which healthcare professionals and patients, and in this case, men, either at risk for prostate cancer or who have prostate cancer, work together to decide on the best test or treatments based on the most up-to-date scientific evidence, but also taking into account the man's preferences and values and goals for treatments. And that's different for every person. And so many of you have heard about some of the, I guess, evolving recommendations for prostate cancer screening. There, you can choose to get a PSA test or not. The men at average risk, there are guidelines for that, but also men who are at higher risk for developing prostate cancer include men who are African American, men who may have a first degree relative like a father or a brother who's had prostate cancer, or men that have clusters of cancer that run in their family or a very, very strong family history of cancer. And so in those cases, you may want to make a shared decision with your clinician about possibly starting screening a little bit earlier. And I would be remiss if I didn't say there are pros and cons of prostate cancer screening. And so it's really important to have an open and honest dialogue about what your goals are, what your concerns are, and if prostate cancer testing and screening is right for you at that moment. So it's really about partnership and communication with your healthcare team and making a decision that fits your particular situation.
Perfect. That's so great. Dr. Shockney, what are your thoughts on this?
So one of the things that I think is important is to know, what will you do with the results? So screening is screening, but what the test results from the screening are should really be a driving force regarding that decision making as to, if you say, well, I'm not going to do anything if I've got an elevated PSA, then it raises a question, what are we doing the test for? I'm glad that Dr. Langford mentioned about clusters within a family. We do have to pay attention to families who have breast, ovarian, melanoma, prostate, particularly diagnosed at a younger age than average, and pancreatic cancer, because those particular cancers live on a particular gene mutation called BRCA2. So we just can't look at the men in the family. We also need to be looking at the ladies in the family also and see, do we see a pattern on the maternal side or the paternal side that might mean that there's a genetic predisposition as well.
Fantastic. I love that point about what would we do with the information. And I would say that's just probably the most critical thing to ask about any test that we're going to ever do in medicine. And, you know, to just think in advance of what would I do if the results were positive or negative, and to ensure that any test that we would do would actually change management. Otherwise, it's not worth doing. So I'm so glad you brought that up.
Mhm. And I think it's also important to remember that there's different steps. So you may choose to get the PSA screening test, and you can do that. But that doesn't mean that you have to do all of the next things right away, or if at all. So there's a decision about whether or not to get prostate cancer screening. And then if it turns out that you do, if you have an elevated PSA, because elevated PSAs can happen for various reasons. Sometimes it's due to prostate cancer. Sometimes it's because you have an infection. Sometimes it's because of enlarged prostate. So then you're making decisions about, do we get biopsies? What kind of imaging do we get? And then if you happen to end up being diagnosed with prostate cancer, then there's decisions about if it's low risk, early stage, localized prostate cancer. What are my options? If it's a more advanced prostate cancer, there are other options. So I just wanted to mark the point that you can make a decision at one point and take your time and not maybe make a decision right away or at all for the other steps. So it doesn't preclude you from taking the next step if the next step is right for you at that time.
That's a really good point. That's something that I emphasize with patients all the time, and also in some of our writing, how really these are all distinct points in the decision process. There's a decision about screening, there's a decision about biopsy, and then for men who are diagnosed, there's decisions about treatment. For men who have a negative biopsy result, or maybe an intermediate biopsy result with a pre-malignant lesion, there's decisions about the next test or doing more biopsies at a later date. So there's lots of later decisions, but you're absolutely right. You're not committing to a lifelong path. There's one decision at a time, and we take the information that we have available and hopefully have, a mutual conversation between the patient and their family and the physician about the goals and preferences. Perfect. Okay, so let's move to the next question, which is decision-making about treatment for early stage prostate cancer. And then after that, we'll move to advanced prostate cancer. So beginning with early stage prostate cancer, let's start with you, Dr. Shockney, for this one. What would you say about decision-making in this scenario?
I think one thing that is important is to make sure that the physician specialists have a lot of experience with early stage prostate cancer, that it isn't something that they just do a few a year, they do a whole ton of them a year. And to find out, what are you qualified to have? Because there are various treatments. It could be a surgical intervention, it could be radiation, could be hormonal therapy, or a combination of these. But based on the size of the prostate cancer, whether there's lymph nodes involved, how old you are, what your general health is, are there other chronic illnesses that you have that might result in certain types of treatment being a higher risk to your life. If somebody had, for example, congestive heart failure, I doubt that we would be embarking on a surgical intervention, because general anesthesia would not be in his best interest, for example. But hearing from these specialists, and a surgeon is very different than a radiation oncologist, and hormonal therapy is very different than surgery or chemotherapy as well. But learning what are the risks, what are the benefits, how were those determined for your personal situation? And we also are supposed to be discussing out-of-pocket costs, which I don't think we do a very good job of here, at least not here in the United States. But the American Society of Clinical Oncology, ASCO, golly, 16 years ago now, made a decision to alter one of the standards related to decision-making for treatment. And it was the patient needs to understand the risks, explained in layman's terms. They need to understand the benefits and how long those benefits would last. And what is the out-of-pocket cost for the patient? Because there may be a treatment that that patient says, I'd like to do that, but I can't afford to do that because of whatever their copays and deductibles are. And they don't want to lose their house in order to have their preferred treatment. And if the difference is only going to be a couple percentages regarding long-term survivorship, then they probably are going to say, I think I'd like to hold on to my house and live a pretty normal life afterwards, versus I might need to move in with my daughter and still have a great outcome, but was it worth the trade?
Those are really great points, Dr. Shockney. Thank you so much for bringing that up. And I'm so glad that now there's more attention being paid to really the financial toxicity of cancer in general. And, you know, fortunately, I think this is finally hitting the airwaves a lot more. I saw some studies last year even about parking for oncology patients as a major cost, especially if you're coming for repeat treatments. So there's so many facets to this issue of cost. The cost of the treatment, but then all these other costs that come with it, things like parking or opportunity costs from, you know, missing work or other things. So thank you for saying that. Dr. Langford, what do you think in terms of shared decision-making for treatment in early stage prostate cancer?
Right. So there were some really good questions posted in the Q&A about, you know, should you take one treatment or another? Some of you may be familiar with this idea of patient decision aids. And so we'll be following up with the information at the end, but there is the Ottawa Research Hospital in Canada has a really great patient decision aid inventory. And that's a good place to start. So they have several that are posted related to early stage prostate cancer and what's the best decision for me. And broadly, the goal of patient decision aids are really to provide you with as balanced of information as possible. They're not designed to persuade you or push you in one direction or another. So for many men who have early stage prostate cancer, there are a variety of choices. Some of the more common ones are active surveillance, radiation therapy, or surgery. And there are pros and cons of each of those. So if you look at one of those patient decision aids, it'll really give you background information about what you need to know about each of those options, what the side effects would be for each of those options. If you chose to do active surveillance, for example, in the moment, you can always choose to do something else later. But the idea with shared decision making is that the situation is usually that you have many different options and neither option is like, quote unquote, the best or only option to treat it. And so for some men, they may say, okay, I have early stage localized prostate cancer. I don't want to do any surgery right now. I'm perfectly fine doing active surveillance, and I'm going to work with my healthcare team to decide a schedule of when I'll come back and monitor it. And for some people, that might be every 6 months. Other people, that may be every 3 months, or some other interval that they work out with their healthcare team. For another man, they may say, wow, even though I have early stage, slow growing prostate cancer, I'm going to think about this every day and I want this out of my body. And I'm willing to take surgery or I'm willing to do radiation therapy, and I'll figure out the potential for incontinence and sexual dysfunction later. I cannot be worried about this all the time. And that would be a good decision for that particular person. And so when we're thinking about shared decision-making, we're often talking mostly about clinicians and the patient. But for many men, they might want to consult their partner, or they may want to consult their adult children, or maybe their best friend, whoever is important to you that you want involved in that decision to help you figure out what you want to do. That's okay. And there are also men who don't want any family members involved, any friends involved. There are people who want to make that decision on their own, only with their clinician, and they do not want any of their family members involved. And that's your decision as well. So I think that the main takeaway is that there are many options, and it really depends on what your goals are for treatment and what you want at that time. And you may change your mind later, and that's okay. But it's really about what you want, your values, and your preferences at that time.
Great, thank you. And thank you for bringing up active surveillance. In fact, nowadays the guidelines recommend active surveillance or monitoring of the cancer as the preferred option for low-risk prostate cancer. So I think it's important for many men with early stage disease who are newly diagnosed to know that they don't necessarily need to have upfront treatment. If the cancer has favorable features and it's not thought to be very aggressive, then a great option could be monitoring, continue to reassess, and you can revisit the decision. As with everything, continuing to revisit this with your physician, I think, is always a good idea. Okay, great. Let's move on then to advanced disease. We'll go back to Dr. Shockney. What would you tell patients who are facing advanced prostate cancer? I know you have a lot of experience in this area, so hopefully you could share some insights.
Sure. So obviously this is taking a different path in the road, that we're not looking at creating the ability to be cancer-free, but instead, what can we do to control the cancer, have the patient live in harmony with this disease, and definitely do our best to preserve quality of life. Quality of life needs to always outrank quantity of life. And I want to begin by giving you a patient example, a patient story. And the story actually is a very personal story because it's about my own dad, who had advanced prostate cancer, was diagnosed initially with an earlier stage, and then 10 years later was diagnosed with advanced disease. And I felt that it was really important for him to be very active in the decision-making process, and he wanted to be. My dad was a German farmer, first-generation German here in this country, and he was still farming when he got diagnosed with his advanced prostate cancer. So when he met with the doctor, of course, I was with him, and I'm trying to balance between being a daughter and being a clinician, which is a tricky fence to ride back and forth sometimes. But the doctor who specialized in advanced prostate cancer said to him, well, I think that we should start with this chemotherapy agent. And let me review with you what the side effects are. And my dad said, wait a minute. I want to know what all the deals are. And I thought, are we buying a piece of farm equipment? What's going on here? And so the doctor said, oh, okay. And I said, yeah, you should tell him all of the options. Just don't say this is the one I usually use, because I think it's the best one, because it may not be the one he wants to pick. So he did go through the various choices, including doing nothing, which is a choice. And my dad said, well, it sounds like the best option is an option that isn't going to let me still be a farmer. And the doctor said, well, sir, don't you think you should be retired by now? You don't say that to a German farmer ever. And my father got really in a huff about it and said, no, I enjoy being a farmer. I feel the need to be productive. I was taught, if you're not productive, then frankly, you should be dead. And he says, I taught my daughter the same thing. And he said, so it sounds to me like what you're describing with all of these side effects, I'm not going to be able to still harvest my crops. I'm still not going to be able to go out there and plant my seeds. And so I'm done. And my father got up and was ready to leave and to choose the do nothing path. And I said, wait a minute, sit back down. So I asked the doctor, tell me how much you know about farming. And he said, I don't know anything about farming. And I said, well, you got to know something about this patient and his career path that he's passionate about. It is what brings him his greatest joy. And you heard him say that he'd rather be dead. And that's the path he's taking with you right now by saying, I'm not going to do any treatment because you've just told him he can't be productive anymore. I said, now farmers have seasons, planting season in the spring, harvesting season in the fall. Their downtime is summer and winter when they get their equipment fixed, or they're doing soil samples to see what nutrients does the land need to produce a good crop for next year. Couldn't you give this patient his treatments during his downtimes and then give him drug holidays during his busy farming times? And the doctor said, well, I've never done it that way before, but yeah, we could like knock the disease down. He could get back out on the tractor, I guess, and knock the disease down. And then my father said, and then get back out on my combine so I could harvest my crops. And the doctor said, yeah, we could do that. My father said, sign me up. So it's really important that you make sure that the doctor knows more about you than just your pathology. He needs to know who you are, what is important to you, what are your goals, your current career goals, your life goals. What is it that drives you and motivates you? There's some very specific questions that are on the back of our ID badges at Johns Hopkins. I hope no one has to read these questions anymore, or I'd be really annoyed with them. But the questions are very pertinent, and I want you to think about them. How much do you know about your cancer? How much do you want to know about your cancer right now? What are you hoping for right now? What are you most worried about right now? And tell me 3 things that bring you joy, because those 3 things are things we're going to try to preserve, because that's part of how you are defining your quality of life. And so in sharing that kind of information with your clinician, you're probably going to have a better experience, because that person's going to know you beyond the fact that you have prostate cancer. And hopefully will engage in also in asking you more questions about these kinds of things, particularly those 3 joys that carry great significance to you. And my father's number 1 joy that he told him, he says, is being a farmer. He said, I'm going to farm as long as I possibly can. I love it. I love doing it. It's important to me. So you can see how that made a paradigm shift from I'm not going to do anything to, yeah, sign me up. And in doing so, obviously, he lived much longer than doing nothing. And he was very happy with the way that the schedule worked out and accommodated his ability to do what he wanted to do.
Well, thank you so much, Dr. Shockney, for really sharing your personal story. It's an amazing story, and I think just really exemplifies the importance of shared decision-making and patient-centered care, and just really being honest with your physician as to what you really truly care about and what's driving your decision. Because in this case, if it never came out that the whole concern was with the schedule, then this modified treatment plan could not have even occurred. So
Right.
It just shows how open communication back and forth about the patient's preferences to the clinician and the clinical team is just so critical. That's fantastic. Well, thank you. Dr. Langford, what are your thoughts about shared decision-making in advanced prostate cancer?
Yes, and I just want to echo, thank you, Dr. Shockney. That was such a wonderful example of being a loving, supportive daughter and a good clinician, but taking that daughter role. I will say that for later stage prostate cancer, and especially for people like me who are friends and loved ones who sometimes may be supporting someone who has prostate cancer or some other illness, that we remain respectful of the patient and making sure that they stay in charge. I think sometimes as daughters, as wives, as brothers, as sons, sometimes we love the patient, and sometimes we want them to do what we would want them to do because we want them to be around, and they may or may not want to do that. They may want a more conservative course of treatment depending on how advanced the cancer is. they may have a goal to extend life. And so there are treatments that you can do to make you live longer. And sometimes that comes with not feeling so great. They may have a goal that, you know what, after a certain point in time, if this is not working for me, I'm going to stop. And we have to respect that as loved ones and friends, that just to be respectful of what the patient wants, and really in some ways that we're taking a secondary role and affirming that we respect and support whatever they want to do, and that the patient is really driving the bus. So I just want to say that. So I'm a researcher and a healthcare professional. And so I know even in my own life, sometimes my own opinions can be a little bit louder than they should. So just really respecting the patient. And again, back to what I mentioned earlier, patient decision aids, they're also decision aids around, okay, I have metastatic prostate cancer. What are my options? And then, you know, for some people, depending on where they are in their cancer journey, you may start thinking about comfort care and palliative care and other choices. And that can be difficult and scary. But I think with many choices that are difficult and scary, at least when you have information, correct information, and knowing what your options are, and support systems that often many cancer centers can provide, or community organizations like US2 International or the American Cancer Society, there are many ways to find support wherever you are in your cancer journey. And just remembering that really the decision is really yours, and that at every step of the way that you are clear about what your goals and your values and your preferences are. And those may change over time. And again, I always use that example. Some people say, I want to live to 100. And other people say, well, wait a minute, what is that going to look like? And maybe your goal is just, or not just, but maybe your goal will be, I want to feel as good as I can for as long as I can. And once I cross the threshold where I'm not feeling as good as I want to, or good enough, then I'm going to stop treatment. And that's an option as well. And so I just wanted to throw that out there, because I think sometimes, especially patients, don't always feel like they have permission to articulate when their stopping point is for additional intervention.
Thank you, Dr. Langford. That's great. And actually, we are going to talk about end of life and palliative care a bit later. But our next topic actually follows directly on something that you brought up, which is research, and including more specifically clinical trials. I know this is an area that you have studied quite a lot. So can you talk a little bit about the shared decision-making around clinical trial participation?
Sure. So clinical trials broadly are research studies that help find new ways to either prevent a disease, diagnose a disease, treat a disease, maybe manage symptoms from a disease. And then there are also clinical trials that focus on behavioral aspects of health. So it might be looking at how a particular eating pattern affects cancer risk, or how reducing smoking or stopping smoking in a, helps reduce risk or effectiveness of cancer treatment. There are also clinical trials and health research studies that are looking at how to support caregivers and the family unit during a health crisis. So clinical trials are broad. I think historically, many people think of clinical trials as only something for people who are like really, really sick. But I give the example, I'm in a clinical trial. I'm in a phase 1 clinical trial actually for the COVID vaccine. So phase 1 trials are first in humans, and I'm in a trial, and that's preventative. So with clinical trials, sometimes people want to make a shared decision about whether or not to participate in a trial. For many cancer clinical trials, especially if you have more advanced disease, oftentimes it will be your oncologist or maybe your urologist bringing it up. But you may see a clinical trial that is looking at a particular screening tool, or a particular behavioral aspect where you might be doing exercise or some other kind of behavioral intervention that's designed to prevent a disease. And in that case, you may have enough information based on what you get from the informed consent document or the flyer about the trial or the website. And in some cases, you may not necessarily want to or need to involve a healthcare provider. But again, in many cancer centers where there are ongoing cancer clinical trials for prostate cancer and other other cancers, oftentimes it's the oncologist inviting the patient to participate and talking about some of the risk and benefits of considering participation in a clinical trial. In that way, again, it's that collaborative process of talking about why you may or may not want to do it and getting your clinician's perspective, if that's what you want, and then deciding for yourself if being in a clinical trial is right for you. It's important to note the decision to participate in a cancer clinical trial is absolutely independent of your routine clinical care, and that will not change the quality of care that you get. You will always get, you should always be offered the best standard of care. So being in a clinical trial is absolutely voluntary and optional, and it's a good decision for some people. For other people, it's not something that they want to do when they're going through active cancer treatment, and that's fine too. It's really a voluntary, optional option. But as you mentioned, my dissertation research was actually all about enhancing minority participation in clinical trials. And we know it's pretty well documented that people in the world don't really know that much about clinical trial options. And oftentimes people are never invited. And there is good evidence that if you are a racial and ethnic minority, you may be less likely to be invited. So I really advocate for people to at least know that clinical trials are an option and to research them. And if it's a good decision for their situation, to consider participation.
That's fantastic. Dr. Shockney, do you have some comments to add surrounding shared decision-making for clinical trials?
Yes, first of all, Dr. Langford, you did a superb job in explaining that. Thank you. It makes my job far easier. One of the things that I try to stress to patients is the only way we come up with new and better treatments is through clinical trials. We don't have any other way of doing evidence-based medicine without participation. And for patients with advanced cancer, this might be their legacy, frankly, if they are participating in a study that may not benefit them at all, but is paying it forward for the next generation, perhaps. So again, it goes back to motivation. What is it that motivates someone to want to engage in something? Also, we touched a little bit about financial toxicities. Usually in a clinical trial, there may very well be additional tests or appointments and such that need to take place. The majority of clinical trials will have built into its budget the opportunity to give a patient a parking voucher, so they're not paying for that additional trip that they made. I'm trying to encourage more and more researchers to pay attention to what time we're asking a patient to come in for that extra visit. I don't want them having to take off from work if they're still working. That's really not fair. That we are the ones that need to be flexible because we're the ones that are asking them to participate in this study. So if we need to get blood work done, why don't we do it at 6 p.m. rather than asking them to come at 1 o'clock in the afternoon? If they are still working, that doesn't make a whole lot of sense. The tests and such that are done during a clinical trial are either standard of care that will be paid for through the insurance company or are covered through the clinical trial. And I know that's a concern too of, gee, I'm going to have an extra whatever done to me. And I know I just had one and I had to pay $150. I don't want to do that. So we need to be forthcoming with giving answers to those questions rather than the patient just thinking about them and not feeling comfortable saying, I don't have $150 to do another copayment or deductible for that. I'm hoping that most patients, and as you heard mentioned in my bio about me that Terry did, have a navigator, have an oncology navigator. Oncology nurse navigators are becoming more and more plentiful, which is good news. These are individuals that do get to know that patient very, very well. They should be following the patient from the point of diagnosis all the way through into long-term survivorship or to end of life. They have resources that nobody else has. they've got taxi vouchers from an advocacy organization. I have one advocacy organization that's specific for patients in Maryland that have breast cancer, and they will pay for Mary Maids to come in every Saturday while they're getting their chemotherapy and clean their house. And a lot of our chemotherapies timeline is going to be 3 to 4 months, and patients love that. They will bring food for the entire family, and they will offer catered meals or groceries brought. They will specialize in low salt diets and diabetic diets and such as well, from the point of diagnosis through to the end of active treatment. They always provide transportation for patients. They've even stepped up and been covering copays for hormonal therapy. I mean, they're an extraordinary advocacy organization. And I have access to all of that for patients, so I can redirect. I look at their at their household budget and say, you've got $800 for your rent, and you've got almost $1,000 for your food each month for you and your family, and here's your gasoline, and here's this, and here's that, but you don't have a prescription card through your insurance. And we're going to be giving you some oral medications that are going to be expensive. So let me do two things. Let me get a drug discount for you through the company that makes the drug. And then let's reallocate your food money, because I can get you food, and apply your food money to pay for those drugs, because those drugs are important, and I want you to adhere to the treatment plan and take those drugs as prescribed. So ways to overcome some of these financial toxicities is available. And that's what navigators are tremendously good at doing, that, and patient education and psychosocial support, and asking, what milestones are coming up that we need to preserve while you're getting your treatment. You just said your daughter's getting married in 3 weeks. I sure don't think we should be operating on you then in 2 weeks. But if somebody doesn't ask those things, patients can be so anxious to get on with things that they forfeit really important milestones. I only want you to give cancer what it needs. I don't want you to give it any more of you or any more of your family either. So that's pretty daggone important.
Great, thanks, Dr. Shockney. That's a really good point about the importance of clinical trials to discover the next standard of care, and that this is not testing unproven therapies. It's when we're not sure if something could potentially be better than what we have now, and it might be, or it might not be. But I also like your point about the cost of treatment, and how oftentimes on a clinical trial, these things may be covered in the trial. Actually, right. We're in the middle of conducting a clinical trial right now related to genetic testing, which is ironically our next topic. And in our genetic testing trial, men who are eligible for genetic testing, who have prostate cancer, either undergo genetic counseling through the traditional pathway with a genetic counselor, and then they decide whether or not to get the test, or they are randomized to an interactive web platform that we created to give genetic education, and then they decide if they want the test on their own. We're trying to determine whether we could make electronic the process of pre-test genetic counseling, because there's currently a shortage of genetic counselors. So, many patients have to wait a long time to see a counselor. There may be additional payments for the genetic testing itself. So in our study, people can see the genetic counselor sooner and get the genetic test for free if they choose to have the test. So that would be just one practical example that I'm working on just in the here and now that relates to this, and shows how it is possible that there could even be some conveniences provided for participating in a clinical trial. Like Dr. Langford was the first in our group of colleagues to receive the COVID vaccine thanks to participation in a clinical trial. So great. So let's move on then to genetic testing. Perfect segue. Dr. Langford, we'll head back to you. Can you talk a little bit more about shared decision-making surrounding genetic testing.
Sure. And you did, that was a great lead up. So genetic testing is the use of tests to see if you have inherited genetic mutations or changes that might put you at greater risk for developing a particular type of cancer. So there's kind of two different groups. So there are people who may consider genetic testing who do not have cancer, but maybe they have a strong family history of cancer in their family. And tonight's focus is prostate cancer. So you may have, again, a brother or a father who had prostate cancer, but you may also have women in your family who've had breast or ovarian cancer. And many people think of, the BRCA1 and the BRCA2 genes only for women and breast cancer and ovarian cancer, but those genetic mutations actually increase a man's risk for developing prostate cancer. They share some of that same hereditary, genetic mutation. So that's one thing to think about. So if you have a very strong family history of cancer, that's something you want to talk to your healthcare provider about that. And hopefully they're asking you about your personal health history and family health history, but there are tools to assess people's risk, familiar risk of inherited cancers. And so if you and your healthcare provider think that it's a good idea to pursue genetic testing, then you will be referred to a genetic counselor. And if you are someone who does not currently have prostate cancer or some other cancer, but you have a very strong family history, that might change the schedule for which you do screening for prostate cancer, or maybe screenings for other cancers like colon cancer, depending on what they find. So there are people who do not have cancer at all, but have a very strong family history who may want to pursue genetic testing. And then for some men who have prostate cancer, if it's a very aggressive prostate cancer, or if they were diagnosed at a very young age, say 40 or 35 or 28, or if they have metastatic cancer, sometimes genetic counseling may be advised just to see, one, if that will change your treatment trajectory. But if you do, again, if you have a hereditary cancer, that might have implications for your family members, and they may choose to get tested and speak to their healthcare team about whether their schedule for screening may need to start at earlier ages and maybe be more frequent. So I also wanted to just mention, I'm talking about clinical genetic testing, which is available in hospitals and recommended by a licensed healthcare professional. I'm not talking about direct to consumer genetic tests where you pay $14.99 and send something somewhere and get a random report and maybe able to call someone or not. So it's really important that you are talking to your healthcare team about clinical genetic testing, because we know that those are validated testing results that are sent to monitored genetic laboratories, whereas sometimes the direct to consumer genetic test, there was actually a investigation, a report done several years ago where actually one of the government entities sent out samples to a variety of direct to consumer genetic tests, and the results varied widely, even for the same sample. So you really want to be working with a licensed healthcare professional and talking about clinical genetic testing, just to make sure that you're getting the most accurate test and validated tests that you can actually make, be confident about the healthcare decisions that you're going to make as a result of those test results.
Thank you so much, Dr. Langford, for bringing that topic up. That is so important, because the direct-to-consumer genetic tests are not clinical grade tests. And, the panel that a genetic professional would order a clinical grade test can differ based on someone's family history and what is at stake. And so it's very important to have a professional ordering the right panel that is needed in your case, which isn't even necessarily the same for all patients with prostate cancer. Dr. Shockney, let's give you a chance to talk about this issue of shared decision-making surrounding genetic testing.
Yes. So oftentimes it can be influenced by whether or not the patient is willing to even let their family know that they've got cancer. So here we're talking about genetics, which will or could impact his siblings, certainly his offspring, and he may not have told anybody he's got prostate cancer. So it goes back to, what are we going to do with that information? How are we going to utilize this information? If you test positive, what would you do? If you tested negative, what would you do? And I also want to say that, you know, initially when someone is diagnosed, they may not have other cancers in their families. It just may happen to be that they don't. But then 5 years go by and their daughter gets breast cancer in her 30s, and their son gets melanoma, and their brother gets pancreatic. And now all of a sudden we're looking at a BRCA2 gene mutation profile. But we wouldn't have known that until these other cancers happened. And I think it's important for everyone, whether they've got cancer or not, to know their family pedigree for their medical history, not just for heart disease and diabetes and such, but also for cancers. And we live in a different world today. That's an understatement. But rather than 3 generations living in the same house, as was the case some time ago, we're scattered all over the country, or maybe even all over the world. And we don't know what our grandmother died of. We don't know. Or it might be, well, I remember my grandmother saying that she had a female problem. Well, that's a broad category. And you know, what does that mean? But being able to get accurate information, somebody in the family needs to be the go-to person for family history. And usually there is a matriarch or a patriarch that wants to do that and does it really well. But we can't assume that cancer does not exist. I had a breast cancer patient diagnosed early stage, did very well, was African American. And I personally knew her before she was diagnosed. And I said, now I know you've got 4 sisters, don't you? Yes. I said, your mom's still living? Yes. I said, and you are 42 years old, so you were young. Yes. It's really important that you let your sisters and your mom know about your breast cancer. No. She said, nope, I'm not going to worry them. That's not the way we handle things like that in our family. I'm not doing that. And I said, this is important for their medical history. They may need to be getting screenings done, mammography done sooner than they would normally be doing. And we want them to pay attention to their breasts more than what they probably are doing. No. She finished her treatment. She did great. Every time I saw her, I would say, I just want to ask you again. Before I could even ask, she'd say no. Well, 2 years after her treatment was completed, I saw her on Good Friday, and I said, is your family getting together for Easter? Oh yeah, we all go to mom's house. And I said, what a perfect time for you to say, while you're eating your dessert, there's something I want to share with you that Lily's been telling me to do, and I've not done it, and I'm going to do it today. And I feel comfortable doing it because I'm doing fine. And then you can say, 2 years ago, I had stage 1 breast cancer. So she said, I'll think about it. And I thought, well, it was better just saying no. She called me that Monday, right? The day after Easter. And she said, I told my family while we were eating coconut cake. And they were all speechless for a few seconds. And then each of my 4 sisters said, I've had breast cancer, I've had breast cancer, I've had breast cancer, I've had breast cancer. And then my mother said, I've had breast cancer. So, of course, they willingly came in for genetics evaluation, and sure enough, they had a BRCA2 gene mutation. Usually when someone carries a gene mutation, 50% of their siblings and 50% of their offspring will also have that gene mutation. In their case, it just happened to be bad luck, and 100% did. But they all took steps to get their ovaries and fallopian tubes out. And they didn't have any brothers. Their dad had passed away. But it was an enlightening experience for that family. And I told them that when they went to church, I wanted them to tell everybody in the church what happened. Because I said, I'm sure there are women in that church that are in the similar situation to yourself, and maybe they'll do the right thing for their family and go ahead and share that information with their family, because it's so important. We also know that tests change over time. There may be a new test, a new gene discovery, gene mutation discovery, and that would mean that we need to test again, not for the ones we've already done, but for new ones that come about and are developed. And genetic counselors, I find, are very good about keeping good records of if we come up with another one, this is a family I certainly would want to profile, because even though they tested negative, by golly, I think they probably have a gene mutation. So my family tested negative, but they've told us they think we have a gene mutation. So I personally had breast cancer in my 30s, and then my other breast at age 40. My dad was early 60s. My mother had endometrial cancer at the age of 39. So they think there's something going on there. My daughter says, Mom, you're a mutant. I said, I am a mutant. So I'm always, tuning in to find out what other gene mutations are being worked upon and might become available for us to revisit that scenario for the rest of our family, for the future generations.
Thank you so much for sharing that, Dr. Shockney. And those are some really good points. And actually, to your point about, continued discovery in genetics and how the genetic counselors keep track of this, a related situation which may occur is that when someone receives a genetic test, it may show a pathogenic variant, as we call it, or a mutation, something that is currently known to be related to a cancer, or it may be negative. But there's also this middle situation that causes a lot of distress called variant of undetermined significance, which is like we don't know what this means, and there's not enough data yet. But the good news is that if it gets reclassified, so the genetic companies usually update this, once or twice a year with any new data that's come in, and so it may reclassify that it is not associated with cancer, or that it is, but the genetic counselor will typically receive an update from the company, and that information is available on the genetic testing company's portal. So patients can always ask their doctors to check it again, and should just keep in touch with genetics professionals in that situation. Okay, so let's move on. We're actually need to continue on with our timing because we've just had so much great content. And this next topic is really, really important, which is quality of life and survivorship. And how do we do shared decision-making in this scenario? So let's start with you, Dr. Shockney.
So, if we go back 50 years ago, there was only one goal for cancer, for someone getting cancer treatment, and that was to survive their disease and the treatment. And if you were alive, then we felt we did a good job. That should absolutely no longer be the case. It should be survival with quality of life. And that quality of life needs to be defined by the patient and not defined by us. So we should begin survivorship care at the moment of diagnosis. It should not be something that happens at the end of active treatment. Well, now we're going to talk about survivorship care. No, I want to talk about it way back here at the beginning, because I need to know about you. As I said earlier, I need to know you far beyond your pathology. What's important to you? What are you most worried about? What are you hoping for? What brings you joy? Where do you see your life in 1 year, 5 years, 10 years from now? I'll give you a breast example because it is a real example. I had a 29-year-old who was a BRCA2 gene mutation carrier. Though she was the first one in her family to have breast cancer, she was 29 years old. And when I was talking to her about milestones, is there anything significant coming up in the next 9 to 12 months that we need to dovetail with your treatment? I said, I see you've got a new diamond ring on your finger. You introduced this nice young man as your new fiance. I don't know if that means she has an old fiance, but you had a new one there. And that made him giggle. And I said, when is the wedding? And they said, not for 1.5 years. I thought, okay, so I don't have to worry about her being bald for her wedding or being in the middle of treatment for her wedding and having to work around that. Asked them if they wanted to have a family. Yes, we hope to start a family maybe after we've been married 1 year, 1.5 years. I said, okay, so we're going to get you into fertility preservation. Otherwise, the big gun chemotherapy we're going to give you probably will take away your ability to have a biological child normally. Then I said, so I know you work as a bank teller at a local bank downtown, and you told me that you've been there 4 years. Do you see yourself one day as the president of the bank? And she said, oh no. I like being a bank teller because I like the working hours. It's what I do in the evenings and on the weekends that I'm passionate about, and that's my life goal. And I said, tell me what that is. She said, I'm studying to be a concert pianist. Oh, yeah, that's not counting money. That's something different. But I knew that we were going to give her, neoadjuvant chemotherapy. So chemotherapy first, because she had stage 2B breast cancer. So lymph node involvement, pretty big tumor. And to shrink this cancer down. And that the primary side effect of the primary drug we were going to give her would cause peripheral neuropathy. So pain, tingling, numbness of her fingers, which can last a long time and for some even permanently. We were not going to have her come out on the other end as a concert pianist. She may not be able to play the piano at all, frankly. So I spoke to the medical oncologist and said, I've just found out something and we need to rethink what protocol we're going to use. And he was very, very pleased that I had discovered this because we were starting her treatment in 4 days. So he said, oh my God, thank God you asked her about that. And yes, we will do a different protocol. And I told her why we were changing the drugs. And she was very appreciative about that. And she ended up having babies and she ended up becoming a concert pianist. So we need to, as I say at that very beginning, we need to know who you are and what you're all about and where do you see your life down the road here. Even if down the road is advanced cancer that you've been diagnosed with now, and that down the road is a shorter road, we still need to know what were your plans for 1 year, 5 years, 10 years, because it probably was to see your grandson graduate from high school or walk your daughter down the aisle, whatever that it may be. And we need to come up with an alternative way to fulfill those hopes. And I'll talk more about that when we talk about palliative care and end of life.
Okay, perfect. So let's turn over to Dr. Murphy, and he can now lead the Q&A session and touch on the remaining topics and his input for the group. Thank you so much, Dr. Murphy.
Oh my God, this whole first of all, that was great. Thank you all for the riveting conversation. This Q&A was way more intense than I thought it would be. People were asking great questions over here. And so I'm Dr. Murphy, just for everyone. I'm from Northwestern in Chicago. And I'm gonna go over some of the questions that were generated from before this even happened, but there are a couple that are new that I think I better share with the group too. One of them was actually for you, Stacy, Dr. Lowe, so we should just ask that now. So, Dr. Lowe, might you address what veterans might expect from the VA, given legislation to create a Center for Prostate Cancer Research? And then why the continued reluctance to incorporate genetic testing for prostate cancer throughout the VA system?
Well, those are some great questions. And in fact, we have had the privilege to participate in the Prostate Cancer Foundation VA partnership. So our Manhattan VA is one of the centers of excellence, and there's many around the country, and there's a huge push to offer genetic testing. So that is indeed available through this network of VAs. And I think the VA is a great place to get prostate cancer care. We've published studies, for example, showing that the VA really leads the country in offering appropriate active surveillance for low-risk prostate cancer, for example. So personally, I think the VA is an exemplary place to receive prostate cancer care. I know, Dr. Murphy, you work in multiple different clinical settings, and perhaps you have some comments to share on the discussion in general about shared decision-making based on your experiences.
You know, one of the comments from the Q&A was about how busy doctors are. And there's a perception that urologists recommend surgery for prostate cancer, radiation oncologists recommend radiation, and there isn't a lot of discussion otherwise. And I think one of the things that's really tough is that, you know, we're all time limited, right? But on that first diagnosis and the one meeting, the one session afterwards, I think it's a patient's best chance to come in there with some good questions. And so I really ask people to go to us2.org or pcf.org or the nccn.org websites and get armed with some information. Join a support group, talk to people who are peers, so they can come with a few targeted questions to kind of help them frame what's most important to them, and also write down kind of what their goals are. I think sometimes people want just longevity, right? They just want to live as long as they can. They're 55, they have kids in college, you know, or they're 75 and they don't really want to harm their quality of life. And I think treatment goals are a huge part of it. I think we are limited, and I think information is our best thing. So when I tell people when I see people, I give them my spiel, and it's targeted and brief, but full of good detail, and then I refer them to a website and give them brochures that will help kind of prepare them for the next time we meet. So I ask patients a lot to say, hey, you know, we can't go over this all today, but I want you to come back in 2-3 months and we'll have a more directed conversation after you've read. What do you say? Is that fair, or what do you think? I mean, thank you for asking me that question too. It was one of the comments in the chat box as well.
Can I just jump in? Many cancer centers, not all, but many cancer centers have like a patient and family support services group. And so that's another place to get additional information. Mm-hmm. Some cancer centers and health systems also have patient education libraries where there's medical librarians who can help you find information. So that's another resource. And you may want to just ask after your visit, ask your doctor or the nurse to say, if I have questions, is there a particular person or group within the health system or the cancer center that I can call? And there may be additional resources. So I agree that, you know, doctors' time is limited, but a lot of times there's other supports that people may not necessarily know about. And that if they ask, that can prompt them to at least get a referral or be connected to other information or other types of services that could also be helpful.
Yes.
And it could be a nurse navigator for them, or a nurse practitioner that's on the team that becomes their point person. But yeah, knowing what are you most worried about today needs to be answered for that patient.
Yes.
So we've got to address that bar none. Even if we only had 2 minutes with that patient, we've got to address that question, or we run a risk of them feeling that they've been put off, or gee, they're going to tell me to go read something. I want to hear something. So also a list of credible websites that do provide accurate information, because we don't want them just going on the internet and, you know, for $59.95, if you drink this potion, we'll cure you of your prostate cancer, because those websites unfortunately are out there.
Yes.
Want to guide them.
Awesome.
Yeah.
Let me do a follow-up to that question, actually, from the audience. How does a wife get the urologist to understand the disease impacts on the wife? This wife felt like she was never able to ask the questions.
So oftentimes, some of the burning questions that a wife wants to know about is not, is my husband going to live or die, but are we going to have sex again? And then defining what sex is. And if you don't know what the baseline is for their sexual activity, it's really hard to get into that discussion. Even defining what is sex, because what it is to them may not be what I'm thinking it is. And we should never make assumptions based on the age of the patient, whether they are or are not doing something with somebody. Don't even think about it, because you'll end up surprised. You'll end up surprised for sure. And I do think that it's important that we take out a moment to ask the wife or the partner. I imagine you've got some questions that you're wondering about. Are you comfortable asking them today? Is this something that the two of you have talked about before you came? Or are you kind of on your own right now and want to ask to even see, did they discuss it in the car? And he said, you ask, I'm not going to ask, you know, because that's what you need to try to figure out. But intimacy is oftentimes something not discussed in any setting. It just isn't. That people focus on sex and their definition of sex, which is going to usually be sexual intercourse with a climax for at least him and hopefully for her. And that's where their head is, right? That's where their head is. So even knowing how often are they sexually active, and then defining that activity, and what can we preserve? What can we potentially not preserve? And part of that too is going to be what stage is this disease and what the treatments are and what treatments they want to embark on and that they don't want to embark on. And people can change their mind over time. I've certainly spoken with patients that have said, you know, if I'm going to lose my sex life, I'm not doing anything. I'm saying, well, you know what? If you don't do anything, you're still going to lose your sex life eventually. So let's rethink this.
Got it.
Let's think about the timelines here and give a little bit more thought to this. It's wonderful when there's a sexologist as part of the team. That's like, you know, gold. And they're helpful in talking with the wife alone, with the husband alone, and then with them together as a couple, and helping them pave a new way of communication. Usually, it doesn't matter if they've been married 2 years or 42 years. It starts with communication and definition of what do we mean.
Actually has a sexologist, which is a real great benefit for patients and their wives and partners, whatever their sexuality. Dr. Langford, I think you have a perspective on what if it's not about sex? What other ways can kind of caregiver roles come up that are broadly more about the treatment or their role in the treatment?
Right. So I wanted to just mention that many cancer centers have a department or group of that psycho-oncology, and really thinking about the mental health, the emotional health of the patient, but also the caregiver or the partner. I personally just think that caregivers sometimes suffer in silence because, cancer affects the whole unit, but sometimes people feel guilty or ashamed to say, hey, I'm struggling here. Hey, I'm really stressed. I need some help too, because they're not the one undergoing active treatment, even though they're directly being affected. So I think questions like, how are you doing? How is your stress level? Connecting people or connecting the caregiver or the partner with resources like support groups. And again, psycho-oncology. And I would just say for all the partners out there and family members and friends, it's really okay to be suffering as well and to seek out help because, it's hard enough to have someone struggling with their own disease. But if the close family members and friends are also, oftentimes they're dealing with health issues as well. And then on top of that, anxiety, sometimes depression, sometimes stress, which can manifest not only in emotional and psychological ways, that can also manifest in physical ways like disrupted sleep, disrupted eating, and all of that. So it's really important to really take care of yourself and not to be ashamed to ask for help. And so I think many times the healthcare systems and the clinicians sometimes will proactively say, and we have caregiver support groups and we have resources for the family members and friends, because I think as well physically and mentally as everybody can be, it's really helpful for the whole unit.
Okay, so follow-up question, because you are on fire. Tell me a little bit about how a person can disagree with their radiation oncologist, urologist, trying to get these aspects out when it's a limited time period, right? 15 minutes sometimes.
Right. Well, you can take notes, so you can choose to ask questions in that moment, or you can go home and think about it. And I know like my health system, there's a patient portal. So sometimes I email my clinicians, and the big picture is it's your body and it's your treatment and it's your life. So really at the end of the day, the patient ultimately decides. And you may disagree with your oncologist, but not all disagreements are bad. You may just disagree on something that if there was more communication that you could work out. So maybe your disagreement is the timing of the treatments or the aggressiveness of the treatments, or maybe the disagreement is like what you feel like you have to do in the moment, or that you have to make a decision right now. And with many prostate cancer treatments or cancer treatments in general, or any health issue, pretty much almost all of the time, unless you're like bleeding on the street, you don't have to decide right this second. You can say, you know what, I need to think about it. I need some more information. Can we revisit? So I just want to empower people not to feel pressured that they have to decide right away or in that moment. And if whatever the issue is that you're disagreeing with your oncologist about, you may want to get a second opinion, or if it's so egregious that you feel that you're being disrespected or left out, there are other oncologists in the world and there are other urologists, and you may want to consider changing healthcare providers if you truly feel that you're not in a collaborative partnership where you're being listened to and respected. And I would just, my last point is you might want to just understand maybe your clinician is giving advice from the perspective of like just the physical health, right? And that's what many clinicians do. They're there to help treat your physical body, but maybe you are concerned about the physical body, but also the emotional health, the other wellness issues, or maybe it's an issue of you want to take a more natural approach. More and more people now are considering alternative medicine, integrative medicine, and there are some cancer centers that actually offer integrative medicine that are complementary and not either or. So you may be at a place that offers yoga or offers acupuncture or does, ginger or other things, or connect you to registered dietitians. So just because you may have a different way of thinking or healing, that doesn't always mean that it's either or. You can do both and, but I think the main thing is that you really want to be very honest about what you're doing with your healthcare providers or what you're thinking about doing, because if you're doing something secretly, that could impact your cancer treatment and maybe cause some other health issues because they don't know about it.
That's true. This is kind of a out there for all of you guys, and this is for Dr. Loeb as well. Just how should you go about this second opinion? I think a lot of times we get second opinions and the patient will have nothing in their hands but their stories. And it's hard for me to understand, even on the chat right now, people are giving me great information about their Gleason grade or their PSA, but I don't have the full picture, right? How do you maximize that visit for them? Dr. Loeb, you can come off mute too.
Okay, so I can take a stab at that one. I think you hit the nail on the head that making sure all of your records are sent to the second opinion provider in advance is really critical. So I have two scenarios that come up all the time at my office where I am seeing lots of people for second opinions. One of them is that there are no records. And then we spend 30 to 60 minutes trying to track down outside records and waiting for the facts. And the patient and their family are waiting, and their parking meter runs out. And now I'm 2 patients behind, but I'm going to have to go back and talk to them once the records come. So that problem is difficult. The other scenario that happens is that a patient brings a huge stack at the time that they come, but then I spend a while going through the stack of records. So that's certainly better than not having them, but even better than that would be uploading them to the record or faxing them or asking the other doctor's office to fax them in advance, because I go through all my charts even the night before and spend a lot of time reading all of the documents so that I'm prepared and can go through the clinic visit in an efficient fashion, and that all of the time that is dedicated to that patient is spent with the patient, not in the back room reading the stack of records. So I think that the best thing is just to make sure that all the information is available to maximize the amount of time that you have face-to-face with the doctor to actually get the questions answered.
Thank you.
I'll pass it on to you.
I wanted to ask Dr. Shockney. This has come up several times both in the pre-sent questions and also right now. What about, like, how do you differentiate between palliative care and end-of-life care? Like, this comes up with, the urologists don't have to deal with it as much, right? But she gave a great story of being a daughter and a doctor at the same time.
Yeah, so palliative care, it gets a bad rap. Oftentimes when a physician brings up palliative care, it's brought up with hospice. I think it's time to talk about palliative care and hospice. So palliative care should have happened, again, way back here. I want the patient, particularly those with advanced prostate cancer, I want them to have the palliative care specialist on the team from the start, even before they need them.
Yes.
And when my dad had he ended up with a T5 fracture in his spine from just coughing, and his doctor put him on very high doses of opioids, which had him sleeping around the clock.
Mm-hmm.
I thought, this isn't going to go well. And so I asked my dad, tell me have you ever heard the term palliative care? He says, oh yeah, I know what that is. I said, tell me what it is. He said, that's when they put you in a room by yourself in a hospital bed with the side rails up so you can't get out. Forget about safety. And they hook you up to a morphine IV that's running in you all the time. And then someone is assigned to come in and check on you every 24 hours to see when you died. That's palliative care. And I thought, wow, I'm not going to use the word palliative care with my father. So I arranged for my father to be seen the next morning because we have urgent open slots for palliative care. And I spoke to Tom, who is our director of palliative care, Tom Smith. And I said, I've booked my dad for one of your appointments for tomorrow morning. I think he probably has a fracture. I'm not sure. He coughed. He's been in severe pain. He's been in bed. and he's now on opioids and sleeping, and he's a very unhappy camper. And this is not going to go well if we can't fix this in an alternative way than just having him on narcotics. So I said to Tom, I said, my dad is a German farmer. I said, so you got to understand how German farmers think. I said, he's all about productivity. I said, he would have made a good surgeon because he doesn't want to, he wants to, I don't have time to waste. Let's get in, get out, do what we got to do. So I said to him, I said, I know your white lab coat has embroidered on it palliative care. I want the white lab coat off. Your badge says palliative care. I want your badge off, because I have told my father that I have arranged for him to meet with Tom, our quality of life coach at Johns Hopkins.
Wow.
And my father said, well, I certainly need that. That's what I need, a quality of life coach. If I had said palliative care, he would have said no, because of his preconceived ideas. And he wouldn't have trusted me to say, trust me, Dad, what you think palliative care is, forget it. I had to focus on really what is palliative care. It is quality of life preservation or quality of life restoration. That is what it is. Yeah. And they do their darndest to not use opioids whenever possible. So he was seen the next morning. I did ask Tom, do you know anything about farming? He said, I grew up on a goat farm. I said, that's close enough. So I said, Dad, Tom was a goat farmer before he came here to Johns Hopkins to be quality of life coach. My father thought that was great. That elevated that man's knowledge base because he had been a goat farmer. And he asked him those questions that I mentioned earlier. And when he got to his 3 joys, the most important joy was still being a farmer. He said, I've got crops to pick right now. I'm laying in bed. What am I going to do? So doing the right thing, he had gotten some imaging studies done and said, you've got a fracture right here where I think it probably hurts the most. And my father said to me, he knows that because he was a goat farmer first. I said, absolutely. And he said, with your permission, we're going to do nerve blocks and vertebroplasties. And I actually think we could get this pain gone. And we could get you back out on the combine. If there's someone to put an extension ladder on the combine and on your tractor. Now, you don't learn that being a goat farmer or growing up on a goat farm. He went online to learn about farming and to look at machinery. And he said, how old is your equipment? He said, I replace it every 2 years. And he said that it's got a bubble. And if you fell over, the safety feature, everything shuts off. And he said, yes. And he said, great. He said, get an extension put on there because that first step is about 2 feet up. And he said, I only want you out there 30 minutes to 45 minutes at a time. Is that enough for you to realize you're still a farmer? And he said, yes. And he said, all those men you've helped to become farmers, it's time to ask them to help you, which I did. And 10 days later, my father called Tom, cell phone to cell phone, and said, guess where I am? And he said, I can hear where you are. You're out on the combine. What are you picking? He said, soybeans. And he said, thank you for giving me my life back. Life is good again.
Oh my God. So
he
you
spoke
had
to
a
my
real
dad the day before he died. My father called him to thank him for being his quality of life coach. My father never knew he was getting palliative care. Right up to his death, he never knew that Tom, who he saw every 2 weeks, was the director of palliative care.
So I think that's a great point. I can't believe that we are literally at the end of this. You all have done such a great job of, well, first of all, answering the questions in both rounds. Thank you, Dr. Lowe, for the first round. And thank you, panelists. Both of you all were helping me do better as a doctor now. So really appreciate that. But we have to turn this back over to the moderator of this thing. Terry, are you gonna help to close this out?
I am.
All right, thank you. And I'll just thank everybody for tuning in, 154 people. I was wowed by the quality of the questions, and thank you for this webinar.
Yeah, thank you guys all so much. This was absolutely fantastic. I knew it would be, but just to see it in action. Adam, you killed it on the Q&A. That was great. Always love having Dr. Loeb as our moderator, and thank you so much, Aisha and Lillie. We also want to remember to give special thanks to our sponsor, Pfizer Astellas. Thanks to the S2 staff and all the work that goes on behind the scenes to make these webinars possible. Be sure to watch for our upcoming webinars on biomarkers and imaging. And please be safe and sound, everyone. Take care of yourselves and have a really great night. Thanks, everybody. Bye.